All righty, I think I'll go ahead and begin the program. Welcome, hello everyone, and welcome back to the Black Health Trust Weekly broadcast. Thank you for joining us. I'm your host, Michelle. With us, as always, are our moderators, the distinguished Dr. Randall Maxey, nephrologist, Chief Medical Officer of Advanced Community Medical Care Corporation in Los Angeles, and founder of Black Health Trust. Also, Dr. Barbara Nabert-Stevens, who's a pediatrician and healthcare executive, and Dr. Ivan Walks, psychiatrist and founder and CEO of Ivan Walks & Associate. They will present our presenters today. They will introduce our presenters. And so our topic today is navigating the consequences of COVID-19, what you can do if facing eviction and the rise in opiate abuse. Thanks again for being here today. Knowledge is power, Black is beautiful. Dr. Maxey, please begin the program.
Thank you so much, Michelle. And welcome to my co-moderators, Dr. Barbara Nabert-Stevens and Dr. Ivan Walks, and special welcome to our guest speakers of today, who will be introduced shortly. We continue with our underlying theme, common sense, that we have to protect ourselves. We know that those who are unvaccinated are twice as likely to get infected as those who are not. And over 99% of those people being hospitalized or dying from COVID are those who have not been vaccinated. And it's young people. And by young, I mean 18 to 45. But let's get to our program right away, and we'll have further comments later. Dr. Nabert-Stevens, would you introduce our first topic? Dr. Ivan Walks will introduce our second speaker. Dr. Nabert-Stevens.
Thank you so much, and good afternoon, everyone. It is my pleasure to present our first speaker, who is a representative of the National Low Income Housing Coalition, which is a nonprofit organization dedicated to ending America's affordable housing crisis. And her name is Ms. Victoria or Tori Beret, and we invited her to share some insight with us regarding the crisis that we went through over the last 2 weeks with the impending eviction problem precipitated by the eviction moratorium ending, which at the very last minute got extended. So without further ado, I'm going to turn it over to Ms. Victoria or Tori Beret, who will share her insights with us. She's having trouble unmuting.
There she is.
Oh, hi, everyone. I'm sorry. Hi, everyone. Thank you so much for having me on today. I do have some slides. I don't see them. Let's see. Oh, it looks like there they are. Great. So like Dr. Nabert-Stevens mentioned, I'm Tori Beret. I'm the senior organizer for housing advocacy at the National Low Income Housing Coalition. And I'm looking forward today to talking to you about the resources that are available for renters that have accumulated back rent during this time period, and also to talk about the latest eviction moratorium. Next slide. So just for those of you who aren't familiar with NLIHC, we're a national nonprofit. We work on policy, advocacy, and research solutions to ensure that the lowest income people have access to safe, affordable, decent, and accessible housing. We're a membership organization, and some of our members include homeless service providers, developers, housing policy advocates, elected officials, housing authorities, residents, you name it. We have a broad coalition of folks. Next slide, please. So as some of you may have heard, the CDC announced on August 3rd that a new CDC eviction moratorium was in place until October 3rd after the previous one had expired on July 31st. So this was really good news because we knew at the coalition, we looked at the Census Pulse survey and estimated that 6.5 million renter households would be behind on their rent or are currently behind on their rent and would be at risk of eviction if the moratorium was not expanded. So now that this moratorium is in place, like I mentioned, it will be in place till October 3rd, and it will cover up to 90% of renter households, which is, again, a very good thing. It does cover, though, it is available to, so it covers renters who are experiencing or in a county where there is an increase of COVID. So basically when the county will no longer be eligible once they are no longer experiencing a high rate of transmission after 14 days. And you can see which counties are covered under the moratorium by the link that I've provided in the slides, and will go out after this presentation. And then renters must take action to be covered by the moratorium. So they have to submit a CDC declaration, which confirms that they are covered under the moratorium and meet the requirements. And then they also must give their declaration to their landlord, and they should do that through qualified mail, so that it's so that they can determine, or certified mail, sorry, so that it is indeed given to the landlord and they have confirmation of that. Next slide. So in addition to checking to see if they are covered by the CDC eviction moratorium and then submitting the documents that they need to be covered, renters should also apply for rental assistance. Renters can see available programs at the site listed on the slide. So it's nlihc.org/rental assistance. We have on our website a comprehensive list of the 498 emergency rental assistance programs that are available. We've been tracking them throughout the COVID-19 pandemic and have been providing updates as they become open, as they have resources available, and as those resources are expended. We also recommend that renters check to see if they're covered by other moratoriums. So some states, I won't say a whole bunch, but some states do have extended moratoriums that are longer than the CDC's moratorium. So New Jersey, for example, just instituted one. They passed it last week on Thursday, and that will go until the end of 2021. And then if they're facing an eviction, whether it's an illegal one or because they aren't covered by the current moratorium, they should contact legal aid to get further guidance. And there's a couple of legal aid websites that you can go on to check who to call to, again, get connected to legal aid. And then lastly, it's really critical that they call their members of Congress to let them know that this is actually happening to them, that they are facing an eviction, that this is happening across the country. This is what their situation is, and just to really make it known that this is happening to people and this is a problem that needs to be dealt with. Next slide, please. So I mentioned that NLIHC has a list of rental assistance programs. So there's 489 programs in our database. 449 are open, 23 are closed, and 10 are on hold. So far, $3.6 billion of the funds have been approved or distributed out of the $24.6 billion in ERA-1 dollars. So there are two tranches of ERA funds. ERA, again, sorry, is emergency rental assistance. So there was tranche 1, which was passed in the end of 2020, and then there's tranche 2, which was passed during the American Rescue Plan Act. And tranche 2, so programs currently are expending tranche 1, and hopefully will be moving on to their tranche $2 soon. And we have another $24 billion for ERA $2. So this means that 16.3% of the total ERA $1 have been spent so far. Next slide, please. So there is still a lot of money that needs to get out the door. It's important to note that households are eligible for ERA funds if one or more individuals has qualified for unemployment benefits, or for in ERA 1's case, can attest in writing that they have experienced a reduction in household income, incurred significant costs, experienced other financial hardship due directly or indirectly to the pandemic. For ERA 2, the only difference is that the hardship could be happening during the pandemic, but not due directly to the pandemic, if that makes sense. And then they can also qualify by demonstrating a risk of experiencing homelessness or housing instability. And for ERA 1, a household income has to be below 80% AMI. For ERA 2, it is a little bit more flexible, so HUD can determine, mostly it's under 80% AMI, but HUD can make some determinations or can make some changes depending on different areas, whether that 80% AMI stays consistent throughout the US for folks to qualify. And then states and localities must prioritize households below 50% AMI or area median income, or those who have been unemployed for 90 days. And then in terms of the use of the funds, 90% have to be used to provide financial assistance, including back and forward rent and utility payments and other housing expenses. So an eligible household can't receive more than 18 months of assistance under ERA 1 and ERA 2 combined. So they can receive up to 18 months of assistance. And they can receive forward rent assistance, which is really important to know because some programs are not providing that. But they can receive the forward rent assistance, and they have to be, they're given it every 3 months, and then their incomes are revalidated after every 3 months. And then recipients can use up to 10% of program funds for housing stability services. So like case management or having help finding housing that's available, those kinds of things, connection to legal aid, to court services. So we've been urging programs and our advocates to urge programs to quickly and effectively get the programs out the door, making sure that they are visible, accessible, and preventative. So this means that they focus on outreach, especially outreach to the hardest to reach populations, that they think of creative strategies to get the information out to folks, that they provide information about the programs in different languages. We also want to make sure that the programs are accessible. So this means not having a lot of documentation requirements, allowing for self-attestation. So for people to say, I'm experiencing this and signing a form that they self-attest to. And then as well as making sure that folks with disabilities can access the application and can apply and get all the resources that they need as well, and understanding how the program works. And then lastly, we want to make sure that these funds are used for prevention. So if, preventing folks from going through the eviction or housing court system. So stopping people or meeting people before they enter that process, working with legal aid and lawyers to figure out who is in line to go down the eviction process, and work with the landlords and try to get that money out before that process happens, as well as to work on different policies that protect renters, such as right to counsel, which would provide lawyers to everyone who needs it for eviction court, as well as other types of renter protections. So that is my piece, and I know I'm happy to make the slides available for folks, since I have a lot of links on that, and I'm happy to answer any questions.
Well, Tori, I want to thank you for a very comprehensive presentation, but
Great.
I am going to confess that I am confused.
Okay.
So could I get you to step back through this a moment? What if I were a renter who is for the moment safe, but looking ahead for October, what 1, 2, 3 steps do I need to start now? Because from all of the information you gave, it doesn't sound like it's a one-stop process. There are multiple steps, and I got lost in the steps. And I think maybe a lot of people might get lost in the steps.
I think so the number one thing that you should do is, I would say, verifying that you're actually covered under the eviction moratorium. And if you are covered, you need to get that declaration saying that you're covered to your landlord. So that's like number one.
Okay, can we talk about that for a minute, just for clarity? From your first slide, that was a form that apparently you had to download and then send by certified mail somewhere. Now,
we recommend doing certified mail. You could email it. We're just worried that the landlord would say, "Oh, I never received it. Sorry, we didn't get it. So sorry." So that's why we're recommending doing certified mail, just so that there is a record there.
If you don't have email or internet, how can you get that form?
So we have it on our website, but I think that the CDC may mail it to you, and I know other organizations, but we could definitely mail that to folks too, if they don't have internet. But that's a great question. I think there are, I think that is, again, a resource that the CDC could provide, but I can double check on that. I'm actually not confident on that. If there's
Is that something you could send to the Black Health Trust that we get to distribute?
Yeah, definitely.
I interrupted you. That was step one.
Yeah. And then step two, I think, is again to apply to rental assistance programs. And so you can go on our data. I think the easiest way to do it is to go on our website, since we have all of the programs, every single one listed on there, instead of having to search, online for your particular program. And you can go on there and fill out the form. So some of these programs, again, this gets to kind of the heart of the matter, where because they're state administered and basically local programs, a lot of them are local, some of them are state, but they all have different, even though the Treasury has made their guidelines broad, different programs have put different rules in place and different restrictions in place. So some programs provide access to the application as a document, and not just online, but people can complete a document and turn it in if they don't have access to the internet, but other programs don't. But so again, there's a wide variety in terms of what these programs are making available to folks and what they're requiring for folks to submit for their application. But everything is, again, like I said, on our portal, and you can go on there and click the link to your program. So it's either by county, city, or state, and you can click the link, and then it will tell you what the different processes or pieces of the application process are. But like I said, we worked really hard to push the Treasury on making the guidelines very loose, and not loose, but very broad, so that, it's an emergency program. These funds need to get out ASAP. And because it's an emergency, restrictions and guidelines are a little bit different, right? Because the goal is to get this money out ASAP because we're in an emergency. So they, again, made the guidelines broad, but programs are interpreting them, even though there's guidance from the Treasury, in different ways. So we're trying to figure out how to pressure those programs to make them as accessible, as visible, and as preventative as possible.
May I ask a question, Dr. Barber?
Certainly.
So I have two questions. Is redlining involved in who gets how much? And I notice people have to put their zip codes in. So that implies redlining to me. And the other question, if I'm a Black business renter, do I qualify, or just homes?
No, so to answer the first question, actually, the goal is to make this money actually more available to communities that have historically been red listed, sorry. So the goal is there's this process called by proxy, but basically it means that you've been in one of those zip codes that has been redlined or is primarily one of people of color, and that's impoverished, has access or more access, easier access to these funds in this program. So it's an easier, quicker process to get that money out to those communities. So there is a priority there again for those communities. And then in terms of the second question, no, this money is only available to renters, not homeowners. There's a homeowner assistance fund that's separate. And so this is just for renters that are 80% area median income or below. So, I mean, I'm in DC, so I guess 80% would be like $80,000 and below. The area median income here is close to $100,000. So
what about a renter that's a business, like a small Black grocery store that rents?
Oh, like a landlord. Are you saying like a?
No, I can be a Black business guy in the hood.
Okay.
And I rent my business building.
Yeah, we're just talking about residents. So renters in the sense of you're a renter and living in a unit, like this is your space where you live.
Okay.
And is this program available to undocumented residents?
Yeah, 100%. Yes.
It's 100% undocumented too.
Programs
we have case managers at Oasis, because what hasn't been said is most of the clients that we're dealing with don't know how to do this. They don't have access to a computer, et cetera.
Yeah.
And their literacy level is they're not college graduates. So the best way that we've been able to assist is to assign one case manager full-time to help patients. This is not, it's easy for me, it's easy for Dr. Walks, but it's not easy for my patients who may have finished 10th grade.
Definitely, yes. And that's our recommendation. So we have best practices. I didn't get into all of that because I was focusing primarily on what renters can do, but we do have best practices for programs, and that is one of them, is to have case managers work and helping people apply, because you're right, it's very complicated for folks.
So I have a question, if I may.
Sure.
Thank you, first of all, Ms. Beret, for giving us this information. It's so important. The one thing I'm still not grasping is, what's the timeline? If I'm able to get the kind of help that Dr. Jordan is talking about, I get everything sent to my landlord. Yep. Should I expect some help in a week, in a month? I know some of these programs, even though they say emergency, the people administering them don't think it's an emergency.
Right. And again, that varies by program, right? Some programs are doing really great jobs of getting that money out within a couple weeks, maybe 1 to 2 weeks. Others are not providing updates to people about the status of their application, and then maybe getting that money to them a month, 2 months down the line. So
Wow.
It's a big variety. And again, we're trying to say, let's reduce the amount of materials or documents that we're requiring from people. Let's try to get this money out the doors as fast as we can in an effective manner, but we need to, like you're saying, we need to get this money out, because the more we wait, the more landlords are going to say, I'm just going to let this tenant go. And we've been seeing a lot of illegal evictions, even during the Cdc moratorium that was in place before this one. We are seeing illegal evictions taking place. And there is like the center, or there is, sorry, I'm blanking on the group, and I can follow up with that is doing some oversight into this moratorium. So you can report your landlord and fill out a form online. But in terms of what's actually happening to the landlords when that happens, it's not quite clear. So there is a little bit of this oversight process, but I don't think as comprehensive as we would like to see.
I have one other question. I have at least one other question, but I'll limit it to just one other question. Your organization, this is such important work. Aside from the emergency that we're in now, when folks reach out for help, have you all seen backlash? Your landlord knows you had trouble with the rent, so when it's time to renew your lease, or when it's time to do this or that, or if you're trying to get a new place and you have to move, they won't, they'll write down that you asked for help. Are people anxious about accessing the kind of help that you all can offer because they're worried about some backlash down the road?
No, I mean, we have, so actually, okay, that's, I wanted to say initially no, but in terms of, so I guess we haven't had these short-term funding in this type of amount or level ever. In terms of subsidized, in terms of like vouchers or subsidized type of housing, yes, there's, some landlords won't want to rent to renters that have vouchers, and that's a big issue. And there are lots of policies or states and localities and ourselves that are pursuing policies to right that. In terms of this funding, so we are seeing that landlords will end people's leases through not through an eviction, but saying, oh, your lease is actually, like when they get that money, saying, okay, your lease is actually ending like this date. So, so it's not like technically an eviction, because it's just like, oh, well, your lease is just ending. But and that's been something that they've been using to kind of get around, because some programs have been saying, okay, well, you can't evict people if you receive the funding for like 2 or 3 months. So that's kind of some ways in which the landlords are getting around that, and also getting around the moratorium. And so that's problematic for sure. So
thank you.
Mm-hmm.
So there's a question in the chat that is addressing another one of your organization's agendas, which is local action.
Mm-hmm.
And besides complaining to legislators, which are at the state level, at the local level, what can we do in our local communities when we know that the money has been allocated,
Mm-hmm.
and yet we know it's not being distributed?
Yeah, you can talk to your local officials as well, because a lot of those folks are helping to create the programs, as well as provide recommendations to the folks that are administering these programs. And also, if you have like stories or information that you're hearing from folks that have not been able to receive this assistance, I think providing that information to advocacy groups like ours, so we can really raise the awareness about this to the media and create a big kind of create a lot of attention and focus and get a lot of kind of movement to persuade not only the administration, but also these programs in general to take action. The more that we put pressure on them, I think the more that they will have to take some sort of action to change, hopefully. So that's what we're hoping for.
There's another question or two in the chat box. I don't know if you're going to get to those, but just want to make you aware.
Go ahead, Michelle.
Okay, well, with regards to undocumented workers again, or people, are there any safeguards for undocumented when they send the paperwork into the program? In Florida, for instance, they have to send forms to the courts.
Yeah, so that information, we're asking programs to maybe make more clear that they're not going to do anything with that information, but that information, like they are not allowed to like send that and report them, or like the information is just going into their system to be used to give them, to be used so that they can send the money to those folks, but they're not allowed or to do anything else with that information that comes in.
Okay, thank you, Tori. And then not quite sure if you answered this, but how would landlords or developers proactively get protection insurance for prospective tenants? So future tenants.
So this program can cover, or you mean like tenants that are not in their buildings yet?
Correct. Yeah.
That's an interesting question. I think, I don't know. Yeah, I don't know. That's a good question. I'm not sure, because I feel like asking people like where they're getting their income is not, I don't think, allowed, or no, I don't know. You know what? I can't.
Just stay out of those waters for now.
Yeah.
All right. Well, thank you for attempting that. Okay,
Sure.
I hand it back over to moderators. Thank you, Tori.
I wanted to pursue the issue of the great variability in the way these dollars have been distributed and implemented around the country. In reading about this, I read where there are at least 3 states, and I bet you can guess which ones they are, that actually refuse these dollars. And when you look at what has been done in certain, I won't say which, but I'll leave it to your imagination. If you look at what's happened in many of the states in the Southeast, minimal activity has been expended in developing any kind of state or local program. So I'm bringing this up kind of in relation to that previous question, what can we do on a local level? We need to, I would think one of the things we can do is be aware of what actually is happening in our local communities. I was wondering if you would react to that.
Dr. Neighbor, I don't think you need to be subtle. You need to speak out and name names.
Well, one of them is Florida.
Yes, yeah.
I think Indiana's one too.
Indianapolis is a big one. We have partners there that are working to try to make those programs more, I'm like, sorry, my brain is not working today, but more accountable, that's the word I'm looking for. So we really data is the whole other piece of this. So we're pushing these programs and pushed the Treasury too, to say like, these are the data points that you need to collect. So we know that these are like who the program is serving and that they're meeting the needs of the most vulnerable folks in their communities. And the Treasury did outline what type of data points needed to be collected, but some programs have been collecting that information and making it available on data dashboards, others have not. And we're encouraging folks to make requests for that data, so submit data requests to try to create their own dashboards and keep track of that funding. And so we're actually funding some organizations, a couple in Florida, to try to track what's actually happening on the ground and see if they can, again, collect data and try to kind of say like, this is what's happening with this money and we need more accountability, and so I don't know if I'm answering that question correctly, but.
No, those are some good ideas. And when before you leave, if you would put your organization's website in the chat,
yep,
so that in addition to, we will make sure this information is posted on the website, so that people can directly reach out to your organization and address the issues that they are confronting.
That's great.
I do have one last question.
Sure.
What is the magnitude of this rental assistance in terms of dollars?
So there's a total of around $48 billion that is available. And so far we've seen $3 billion. I think one of the other issues is that these programs have not had the infrastructure in place. So a lot of these counties and especially the little smaller county governments or city governments have not had the infrastructure in place to figure out how to administer something of this magnitude. And so I think we've been seeing, different governments build the infrastructure, and that's been taking time. So I think that's part of the issue. We have been seeing that the amount of money that's been going out over the past couple of weeks has been increasing in terms of like how much is going out each week, which is a good thing. But we do need to do this again. It's at all hands on deck as fast as possible, because we're talking about real people's lives here. That if, we know the consequences of evictions. Once you're evicted, it's a downward spiral in terms of finding future housing. We also know that it affects Black and Brown folks way more, higher percentages than white folks. And so there's, there's really big issues here. And we need to, like I said, do as much as we can to put pressure on the administration, on the folks, again, administering these programs too, as well as state and city and local officials. So, and like I said, we have lots of recommendations, and would love advocate support on this. And I'll submit, or I'll put ton of links in the chat. I'll overwhelm you with links for the information that we have. So
Thank you. I wonder how easy it is for American Airlines or General Motors to get a few $1 billion. I bet it'll take about 30 minutes.
Yeah, exactly. I know.
Well, thank you so much for giving your time.
Of course. Thanks for having me, and thanks for all these great questions. I appreciate it.
Dr. Ivan Walks, sir.
Yes, good afternoon. I'm still sort of wrapping my head around what we just heard. The magnitude of this problem and how it impacts people is just huge. Let me take the great pleasure in moving us over to our next speaker, who is Dr. Edwin Chapman. Dr. Chapman has been practicing medicine in Washington, D.C. for over 45 years. He's an internal medicine doctor who expanded his practice long time ago to focus on not only internal medicine, but addiction medicine. Over the past 21 years, he's investigated that complex mix of addiction, untreated mental illness. One of the things that's not in the slide that I know about Dr. Chapman is that he's also reached out beyond the medical community and the stuff that medical folks do, and is working with an organization. He's one of the founding board members, as am I, of an organization called Leadership Council for Healthy Communities that looks comprehensively at the needs of people in the Washington, D.C. area. And it's that kind of comprehensive approach to things, focusing on lay people, which is what the Black Health Trust does. We are an organization focused on communicating useful information to the lay public. And so we've asked Dr. Chapman, who is a widely sought after speaker, widely, in all, not only in medical circles, but in all kinds of circles, legal, policy, and others, to talk about the impact of substance use disorder. It's a huge impact has a huge impact on our community. Dr. Chapman has been written up and written about in the Washington Post, other national newspapers and magazines. He's been on television talking about this issue, and was actually one of our wonderful speakers for the International Symposium that we did along with SUNY Downstate several weeks ago. So we asked Dr. Chapman to come back and talk to our lay audience primarily about some of the challenges of being a physician in the inner city of Washington, D.C. and dealing with substance use disorder, and how he has found a way to treat it and do a great job. Dr. Chapman, could you please talk to us a little bit?
Thank you so much, Ivan, for that kind introduction. I'd like to share my screen, if I might. Can you see the slides?
Yes, sir.
So in the era of this COVID pandemic, we've often forgotten the epidemic that's persisted in our communities really for over 60 years. And that's the drug epidemic. And we're really talking about now the opioid epidemic and the impact that COVID has had in exacerbating that. Even before COVID, starting about 5 years ago or 6 years ago, in our community, the opioids changed from heroin to fentanyl. And here in the District of Columbia, about 6 years ago, we had 20% fentanyl in our drug supply. Today, it's 95%. So we're all aware of the background of COVID and how COVID has exacerbated all chronic diseases, particularly in our community. And we're particularly vulnerable, and you can see a number of cities here. But the diseases that most often are exacerbated in our community are the usual chronic diseases, particularly chronic obstructive lung disease, asthma, diabetes, obesity, kidney disease, and hypertension. And of course, income plays a tremendous part in that. And that's what the past year and a half have actually shown, the stark disparities in treatment. So when we look at the expected deaths in 2020, and on this green line, we can see that we had an exaggeration of actual deaths during COVID, demonstrated by the red line. And the yellow line actually shows what we call excess deaths. And we know during COVID that people were not able to access their primary care because of the isolation. So emergency room visits went down. People died at home with heart attacks and strokes who normally might have come to the hospital. So we see this dramatic increase in these excess deaths because of people dying at home and misdiagnoses because people were no longer getting their usual screenings like colonoscopies and mammograms. So on top of that, we had the George Floyd incident. And immediately after that, the CDC reported a dramatic increase in anxiety and depression in the African-American community 1 week later. So this is just a typical illustration of the psychological effect, the anxiety, depression, what we commonly call toxic stress that pervades our communities on a daily basis, whether it's unemployment, shootings that have exacerbated during COVID. All of this increases anxiety and depression. And that leads to hopelessness, helplessness, low self-esteem, projected anger, and that projected anger comes out in a number of different ways. It can be physical violence, self-medication, or even overeating. So when we put COVID on top of an ongoing opioid epidemic, we have double trouble. So we already knew, for instance, in Washington, D.C., that we're 46% of the African Americans are 46% of the population, but we've been 80% of the overdose deaths for years on end, and that has not changed. So of course, COVID just exacerbated those changes. In addition, we found that we have a number of systemic barriers to care. The treatment for opioid addiction, as you know, involves 3 medications. We have medications, substitute medications, or replacement medications. And the reason why we use replacement medications for opioid addiction is that, or opioid use disorder, is because there's a 90% relapse rate. And that's because opioids so closely mimic the dopamine system. And so experience has told us that if we don't treat it with safer replacement medications, that people will die. So this is a paper that I participated in with the National Academy of Sciences with 9 infectious disease experts. And they were concerned because they were seeing this dramatic rise in hepatitis C, HIV, and endocarditis in the white, rural, and suburban communities. Well, we've had that problem for years. And one of the things that we looked at was on the right-hand side are prior authorizations for one of the or several of the medications that we use. So you're well versed in methadone, which has been around for about 60 years. About 20 years ago, another medication called buprenorphine, which is an office-based medication and a partial agonist as opposed to methadone, which is a full agonist, was allowed through what's called a data waiver. And then the third drug is Vivitrol, or injectable naltrexone. So these are on the right-hand side listed some of the barriers to care. Prior authorization, you have to take a special course, 8-hour course for physicians to prescribe this medication in the office. We lack data integration in our computer systems. We have inadequate workforce and training. There's stigma associated with treatment of opioid use disorder, even within the medical community. And then there are payment and financial limitations. Same day billing. In some places, you can't bill for a primary care visit and a psychiatric visit on the same day. And limits in so-called harm reduction, like needle exchange. There's states like West Virginia and Indiana that, in spite of the fact that they're having increasing infections with hepatitis C and HIV, are limiting needle exchange. And then finally, we know from years that our patients were incarcerated and not sent to treatment. So we have this ongoing set of problems. This is a profile of my patients from about 5 years ago, and it showed that the average age was 52. 2/3 were male. Average years incarcerated, 10, greater than 50% required mental health medication. So at least 50% of the patients suffer from anxiety and depression, but 90% of the patients have a mental health diagnosis. And of course, the HIV and hepatitis C penetration in our community, because it's been around so long, and these are older patients, is very high. 90% smoke, and we have a very high homeless or unsafe housing. So that reduces life expectancy. About 2 months ago, I was on a panel with the American Society of Addiction Medicine, And Dr. Helena Hansen, who's now at UCLA, gave a beautiful overview of the history of buprenorphine. And that history is very dramatic in understanding that this medication was not intended to be used in the African-American community. It was marketed primarily to white and suburban communities because of the fear that it was going to be diverted like methadone on the streets, and thereby, instead of being a Schedule III drug, would be restricted to a Schedule II drug. So we can see in this depiction of New York City that there's a favor for methadone in Black zip codes and buprenorphine in white or higher income zip codes. A study out of the University of Michigan last year showed that only 2.7% of buprenorphine prescriptions are prescribed to African Americans. So you can imagine that it has not really been marketed at our meetings in our community. So barriers to successful treatment obviously include behavioral health. And this was a study that we did at Howard University several years ago, showing that 42% of the patients were requesting the need for more mental health services, but only 2% of the psychiatrists in the country are African American. So we can see again this depiction of the social determinants of health, and housing leads to the list. We have a very high homeless population, and of course COVID, as we heard from the previous speaker, is going to exacerbate that problem. A lot of my patients are now living in hotels, and we don't know what's going to happen in a couple of months when the moratorium for housing stops. So we know that that treatment saves money and saves lives. But we've had this dramatic increase in spite of that in overdose deaths during COVID. Here in the District of Columbia, we had a 60% increase from 2019 to 2020. And that increase for the first 3 months has been stayed pretty much the same. So what lessons have we learned from COVID and the opioid epidemic? We can see that incarceration, we've emptied a lot of the jails as much as possible because of the crowding. We've also tried to get housing for patients because we know that shelters in many instances are overcrowded, so they started putting patients in hotels. It saves money on personal medical, mental health, and self-medication costs. But isolation is the enemy. And of course, the idea that we have to separate patients and keep them isolated at home is just the opposite of what you want to do with a patient who has an addiction. Isolation is the worst thing that can happen. So we've seen a dramatic increase in alcohol use as well as opioid overdoses. And of course, decreasing community infections, homelessness, crime, and violence are obvious goals. So what the combination of COVID and opioids should tell us with the job losses, the insurance losses, is something that Martin Luther King told us years ago, that we're all tied together, we're interdependent. So we had this sudden upsurge of people coming out and rallying around these issues. But the question is, how long is that going to last, and where is it going to go? And we know from the last election and the residual that we still have great divides in this country over race and racism, sex, sexism, class and classism, and all the things listed here. We still have people who feel that substance abuse is a moral failing, even within the treatment community or the medical community. Is healthcare a right? Does everybody deserve to have insurance? Is housing a privilege? Even obvious questions, is COVID real? Should we wear a mask? Why should I get vaccinated? We have really seen a tremendous questioning from certain sectors of the country regarding science. But when we look back at how opioids or substance abuse was treated in our community, we know that pre-emancipation, that there were two diseases that were made up by Samuel Cartwright. Drapetomania said that slaves that ran away from their master were crazy, and dysesthesia ethiopica, which meant that patients, that if you saw African Americans gathered together, that there must be something wrong with them. So the vagrancy laws came about post-emancipation related to intoxication, and that extended today to mass incarceration. And of course, we know about Michelle Alexander's great work. So what we're faced with is the fact that we have this long history of maltreatment in our community. And for us to treat, we have to reverse engineer all of the damage that's been done over the past 60 years. We have many children who are parentless or in foster care, or have been in families where their parents were incarcerated, came out, couldn't get jobs. So we're really looking at the aftermath of what has happened over the past 60 years in our community, both with the opioid epidemic and cocaine. And these are several of my patients. The one in the lower left-hand corner is my longest patient, who was started treatment with me at the age of 57. He's now 73. He's never been to the hospital and doing quite well. So what are the tenets or requirements for health insurance? Health insurance is not just a piece of paper. These are the requirements for equitable health care. Of course, you have to have universal coverage with no work or community service requirements, which was something that Trump tried to put in. We need equitable services regardless of the neighborhood, affordable coverage, high quality services. They need to be cost effective, and they need to be close by. So this is a depiction of the siloed healthcare system that we currently have, with mental health treatment, drug treatment, and primary care, all in different locations. So our challenge is to try to integrate the three. And this is a picture, if you look closely in the upper right-hand corner, you'll see Dr. Walks. And this was a meeting of LCHC, or the Leadership Council for Health and Communities, that actually brought pastors in the community and medical personnel with a predominance of mental health providers. And you can also see Dr. Patricia Newton, who unfortunately passed last year. We had top psychiatrists in the meeting, Dr. William Lawson. I put an arrow there. He did come to the meeting. He was a little late, but this was the fact that we recognized long ago that we had to do something different. We had to be social engineers to get service not only to our care providers, but also to the community. So this is a treatment design that I've been working on for the past 7 years using telehealth, because I'm not a psychiatrist. So I knew long ago that I needed help with these patients. And I thought telehealth would be the answer to that. People didn't want to listen to that, but COVID has dramatically changed that possibility. So one of the things that Dr. Walks and I are trying to accomplish is to be able to serve these patients using telehealth, using one site, whether it's my office or his office, and we can share services without moving the patient, because these are markedly challenged patients who need social workers, they need peer navigators, and they need all of these services. And we don't care whether they're all provided on the same day or different days, but we can actually provide these services in an effective bundled payment manner, if we can create that. And this shows why. If you look at the blue lines on the right-hand side, on the left-hand side, you'll see the cost of treatment of a patient who does not have a mental health or substance abuse problem. On the right-hand side, the reddish orange line shows that any chronic disease that we look at quadruples in cost if you have both a mental health and substance abuse problem. So it behooves us to treat these patients. And we call this integration of care the social determinants of health, because we now know that 80 to 90% of health outcomes are related to things that happen outside the doctor's office: housing, food, clothing, and just family security. And our previous speaker really gave us the details on the impact of housing and what we're faced with these multiple extended moratoriums. So we can see that this is a study that was just recently reported in Internal Medicine News and nationally, that the United States ranked number 11 out of 11 high-income countries in terms of healthcare delivery. We have one of the highest infant mortality rates, low life expectancy, and as we saw with COVID, the life expectancy in the African-American community lost 3 years in just 2020 alone. The other problem that we have is that we know that as African-Americans, we account for only 5% of physicians, 6% of nurses. So we have a marked structural disparity in our community. This is an article that just came out 2 days ago, reporting that Howard University is going to create a center for research on health disparities. And these are some of the Howard University students last year or the year before, actually, as they advocated for inclusion in a new hospital that was to be built in Southeast DC. And we know the importance of having providers that look like us in the community. So this is just a statement from Charles Hamilton Houston, who was actually Thurgood Marshall's mentor, and he died in 1950 before Brown versus the Board of Education. But his statement was, a lawyer is either a social engineer or a parasite on society. And I think through the work that the Black Health Trust is doing, we all know that we have to be pushers and drivers in our community to get things done. So I'm going to stop there and take any questions.
Dr. Chapman, thank you so very much. We do have a lot of questions. I have a lot of questions. Let me make a very brief statement. From Dr. Chapman's presentation, it's clear that he is all over the place talking with everybody about these issues. And that's volunteerism at a level that is just amazing. Dr. Chapman is one of our most eloquent speakers in this area, and he just goes out and is willing to do this. And I think it matters a lot that we spend that time. I think about Dr. Chapman doing what he does. I think about Dr. Maxey, putting the Black Health Trust together. There's something about people who are willing to give of their tools and give of their talent that we have to acknowledge. So that's my acknowledgement. Thank you, Dr. Chapman. Dr. Chapman, you mentioned a couple of times about the 2% of Black psychiatrists, 6% of Black physicians, 5% of Black nurses. Why is it that this issue of cultural competence and folks who look like us matters so much?
Well, there have been a number of studies. It's been well documented that Howard, Morehouse, Meharry, and Drew put out more primary care physicians who actually go back to our communities and practice. That's unquestioned. The second thing is that there was a study that Harvard University School of Business showed that particularly with African-American males, that they're more likely to see a doctor and follow instructions if that doctor looks like them. So I think we just can't put our health in the hands of somebody else. We've known that for years. It's been demonstrated for years. You mentioned Dr. Maxey's long tenure in educating the community, but that tenure, I was a year behind Dr. Maxey at Howard, and that tenure started well before he got his MD degree. He was taking students down to the Delta. I didn't even know where the Delta was until I heard about the program that he had instituted as a student at Howard University. So that's the kind of activism that we learned in school, and hopefully and know that's the same thing that our students are hearing now, that they are the ones who are going to more likely make the changes and push and advocate for the needs of our community.
So Dr. Chapman, before I let Dr. Maxey jump in, let me ask one of those questions that I get asked sometimes, and I know you get asked, and I'm going to ask it the way it's asked sometimes. So you're giving drug addicts drugs. Why is this medication just treatment that you're doing? Why isn't it just replacing one drug with another?
Well, we now know, as I mentioned, the very, very high relapse rate with opioid addiction of all the addictions. So you can't compare opioid addiction to cocaine or tobacco or alcohol. The relapse rate within 1 year without medication is at least 90%. So when I mentioned that the drugs on the street, which is what most of our patients start with, they didn't start with pills from the doctor's office. Most of our patients, if you talk to them, started self-medicating on the street. 6 years ago, instead of heroin, our heroin supply became infiltrated with fentanyl. And fentanyl is 50 to 100 times more potent than morphine. So you can imagine that what we're seeing is a Darwinian effect. There are those who will tolerate. I have an 80-year-old. I've had 3 80-year-olds who never overdosed on fentanyl. So we're seeing a Darwinian selection. And if you're on heroin or you're using cocaine and somebody puts fentanyl in your cocaine, or you're smoking marijuana and somebody puts fentanyl in your marijuana, that first hit might be your last. And so this dramatic increase in overdose deaths across the country, not only in urban settings now it's going into the rural and suburban areas. It's that transition period where people go from pills to heroin to fentanyl, that they're dying. And we're finding out very quickly whether they're slow, intermediate, rapid, or ultra rapid metabolizers of these drugs.
Dr. Chapman, I'd like to ask a question. First of all, thank you for that outstanding lecture. And we're going to need to bring you back for our medical advisory where you can speak a whole hour. This was outstanding. But I have a concern. I'm a practicing, even though I'm a nephrologist, I recently started back doing primary care. And I have a lot of little old ladies and little old men, church going, some of them preachers, some of them bishops, and they have legitimate pain, usually low back pain, bone on bone arthritis, and they all want narco or oxycodone. And some of them just want cough syrup with codeine. Yeah, but there was a recent article that I read that shows if you just take these people off of that, there's an increased morbidity and mortality. The reason they want these drugs is because Medicare and the federal government will pay for it. They will not pay for non-narcotic pain medications such as CBD or other forms of treatment. I'd like you to comment from the standpoint that many of these drugstore legal prescribed narcotics are damaging to the heart, to the kidney, to other things, but the government encourages it.
So that is the ultimate dilemma, that we have patients who need these medications, and some have been on opioids for their pain for years, and then you suddenly stop those medications. What are they to do? And that is the ultimate dilemma. So we're seeing patients who, because they can no longer get the pain medications that they need, that you've described, they end up going to the street and either purchasing something on the street that they think is Oxycontin, Percocet. They're now making fake Percocet or Oxycontin pills. They call them M30s, and importing them from Mexico, and that is killing some of our patients. So it's really there's a real dilemma in terms of where we are in terms of not getting in trouble with the DEA and trying to prescribe appropriately, as you described, that these patients need. We have patients who need pain medication, and certainly a patient, let's say with terminal cancer, would not be questioned. It's the patients who are in between with the chronic pain, chronic arthritis, et cetera, that really creates a dilemma for the provider.
Let me have one more follow-up question, if I could, Dr. Walks. I recently prescribed Vivitrol for a pastor patient of mine, and his insurance refused to pay for it despite my request of an authorization. So he went to pay for it cash. It was $1,600 a dose once a month.
That's right.
So there are all these barriers. It's almost like the rental assistance program. By the time you get what you need, it's too late.
And again, the first thing that you saw in that National Academy of Science barriers to care that we want to get rid of is the fact that we have these farm benefits managers who never see the patient. I don't even know if they're licensed in the state that I practice, making decisions for our patients for medications that are legitimate. And by the way, Vivitrol is not an opiate. It's an antagonist that binds to the receptor site and is used to treat addiction. And as you said, can be taken as an injection once a month. That decision should be in the hands of the provider. And we're going to have to be proactive, I think, as providers. We've been passive. A lot of times we accept the rejection. I get rejections for medications every day. But I think being proactive means that we're going to have to document, and then as a community of providers, get legal action, just as say a Attorney Crump has done with the police shootings. We can no longer allow others to make these decisions for our patients.
I'm going to issue a challenge to the National Medical Association to take this project on as a priority, working with the Black Health Trust, with you, Dr. Walks, Dr. Nabert, myself. We have to make this a priority. This is not only is it not fair, but it's deadly in our community. And I'm just sick of seeing people suffer and die, and we give lectures on it, but we got to do more than that. So I appreciate your insight and foresight on this, Dr. Walks.
So Dr. Maxey, you just hit on something that I wanted to get back to Dr. Chapman with. Dr. Chapman, one of your last slides mentioned this whole thing about the eviction moratorium, and then our earlier speaker spoke so well and gave us so much good information about it. But we have people of different ages that are involved in this. If you watch some of these shows, you see somebody young who has an overdose problem. You talk to us about folks that are in their 50s, 60s, and 70s that have longstanding opioid addiction issues. Is there a significant difference in how this is impacting young people versus how it's impacting those who are not as young, and maybe even those folks that have families and maybe are trying to earn money to support their families and have an opioid addiction problem? What's that doing to our community?
So I'm glad you brought that up. We've had a number now of young people to die in our community. A 17-year-old, I believe a couple of 20-year-olds, and we don't know, at least I don't know, whether or not they were addicted or whether they were just out and somebody gave them something, gave them a pill. These fentanyl pills, I have a slide, I think you may have seen it in a previous presentation, a bucket with 30,000 fake fentanyl pills imported from Mexico. So these are out on the street now. So it's no longer somebody using heroin and the heroin was laced with something. They're actually pills. And one other thing, these kids are going to parties and they're bringing pills from home, whether it's some of the benzodiazepines, but they go to these parties, and from what I understand, they might put them in a pile and you pick one or take what you want, but they're also mixing it with cough syrup, and they call it lean, and it's in the music. And this was astounding to me. I just learned about this last year in an interview. I was asked about lean. I said, what's that? And the kids call it lean because you know how somebody who is on opiates kind of bends and leans over. Well, some of the music that we're hearing actually has that in the lyrics, in the hip hop lyrics. And they're marketing that to our children who think it's cool. You know, now, you know, when we were in school, we would go to parties and alcohol would be, or somebody might mix up something and put grain alcohol in it. But this is a totally different mix. And if you can imagine taking a fentanyl pill that you think is a Percocet, that's what killed Prince, was a fentanyl pill. 50 to 100 times more potent than morphine. So it's an altogether different game.
Dr. Chapman, let me ask you to comment on something. And while you're doing that, I'm going to see if we can unmute Dr. Lawson, who has a comment or a question. But while we're getting Dr. Lawson queued up, Dr. Chapman, one of the things that occurs to me is as you're treating some of these older folks or these less young folks, how are they then able to interact differently with their families or get back into the families that they may have had to be distanced from because of their addictions?
And that's why I showed you the pictures. One of my patients is actually now the peer counselor in my office. And the way we did that was the Leadership Council for Healthy Communities got a grant from SAMHSA. And it's a 5-year grant, and they assigned this patient to my practice. So he now gets paid from the Leadership Council for Healthy Communities in a pilot demonstration and works with my patients using telemedicine. So when I have a patient in the office, I can actually put that patient in a room and connect them with this peer navigator who's at home seeing the patient. We also hired his wife because his wife never used drugs, but she had the experience, the lived experience of working with him for 30 years. So she can help families understand what it takes to get one back on their feet. So it's been a dramatic experience to see someone who has had years of incarceration, unemployment, et cetera, instability, and you're able to stabilize them for 5, 10, 15 years. It shows how racism has impacted our communities and the fact that we can turn patients around. They want to be turned around.
Amen. Dr. Lawson.
Yes, I want to just emphasize the points that Dr. Chapman has. Dr. Chapman has been an outstanding advocate, speaking every turn he can about the importance of this issue. One of the issues that the Congressional Black Caucus was concerned about, the increase in suicide rate among young Black men. We wanted to see how much of this is related to folks overdosing on fentanyl. How many of those cases are suicide? Unfortunately, we just haven't figured out a practical way to determine that, but just to note that the suicide rate, especially the result of COVID and our experience in terms of the long haul syndrome, where folks having persistent symptoms, is probably higher than is usually reported. The other point that he mentioned is the lack of access. We have the technology to deal with addictions and with opiate use, but these medications aren't available in the African-American community. It's been repeatedly stated that it's a problem, and yet there has been very little movement. One approach that we've had in terms of getting more patients involved in terms of treatment is through the use of telemedicine. I talked to two of the largest telemedicine sites. I said, do you offer Suboxone? And they said, no. So one approach we have to kill 2 birds with 1 stone, we had the technology to expand treatment services to a lot more people. And of course we have the medication, but they're not available in our community. So we have solutions and we need to work to make sure those happen. Black Psychiatrists of America would like to join in your efforts to reach out to Washington Health Empowerment Coalition. We'd also like to be involved. We need to get all of our organizations on the path to trying to address these problems.
So I'm going to ask Dr. Neighbor-Stevens to take the helm for a minute. But before I do that, just briefly, Dr. Lawson, for those of you who don't know him, is one of the most prominent psychiatrists in America. I didn't say prominent Black psychiatrist. I said prominent psychiatrist in America, from the amazing work he's done at Howard University, the work he's done down in Texas over many years. And he's also one of the smartest people I've ever met. So thank you, Dr. Lawson, for chiming in. Dr. Neighbors-Stevens?
Thank you so much, Dr. Watts. I want to take this back down to a different level. And I want to go back to some of the very early slides that we looked at, where we were talking about the huge increase in suicide and deaths by drug overdose since COVID. It wasn't broken down by age groups, but if we are experiencing, I mean, not if, since we know we are experiencing an exponential increase in the drug use and subsequent deaths, I didn't want to make the assumption that the deaths were intentional. And I think we were kind of touching on that a minute ago when we were talking about the quality, if you want to use that term, the quality of the street drugs that are being used. And I want to get back to that because as a parent, we all have known about certain things to warn our children about over the years. It was different thing, different years, but kind of related to the same thing. Now, what can a parent caution and educate their young people about the drugs that are now available in the community? I'm going to go ahead and say it. Back in my day, when I was in college, you didn't have to worry about your weed being laced with anything. But now you really have to be concerned about that. And the same appears to be true for your fentanyl and everything else. Well, I don't know why you would want to take fentanyl, but for your other drugs. So could you speak to what should parents in the community do to help protect our community?
My answer is not to take anything from anybody. I mean, it's really that bad. You can take a cigarette, a marijuana joint, a drink. You absolutely can't take anything from anybody. And I don't know any other way to say it to a child or a grandchild. You absolutely cannot take anything from anyone. They're putting fentanyl in the K2, they're putting it in marijuana, they're putting it in cocaine, they're putting it in everything that they can. Our communities are literally being poisoned. They're being poisoned. And you know, we talked about the older heroin users who transitioned to fentanyl. Now we're seeing marketing to the next generation. And these are business folks. Believe me, these are business folks. And they're always a step ahead. It seems like they're always a step ahead of our interventions.
Let me break in with a question, Doctor. Like your comments on cannabidiol, particularly the therapeutic use of CBD for pain and other things, pro or con? What do you think about that?
So I've never used it. I'm going to let Dr. Lawson kind of maybe answer that. I've always been concerned. I don't know whether it's been absorbed or is absorbable or not. But you know, some of the marijuana extracts have reportedly caused an increase in psychosis in some patients. So I'm a little bit on the fence about where to go with that. But maybe Dr. Lawson can give us.
Dr. Lawson, you want to address that?
Yeah, I have a number of friends who are advocating for it, who seem to think that it's the greatest thing on earth. I tried it and did it. It had a little bit of effect that's made me sleepy. But the problem is not the drug itself. And the evidence thus far is it does not promote psychosis, does not promote euphoria, but many of these companies are coming out mixing it with THC, giving it so that it's more desirable. And I've had several folks who've had fentanyl in it as well. So I just want to take to heart Dr. Chapman's warning that this is among the drugs that we should be very careful if you're going to use it, make sure it's coming from a reputable source, that is not off the street, that is not something handed to you by a buddy, and really be very careful about the drug companies that are putting it out as well. The important thing is that we need to be much more careful than we have been in the past. We got problems with pain, distress, depression. We need to make sure that we don't promote quickie over-the-counter solutions for these problems. And we also need to spread the word there's a huge effort to produce CBD. I just got in an argument with a talk show host about the use of it, who was claiming that this will be the ultimate solution for the Black community. Need to let them know, caution, 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 that these drugs can be used inappropriately, even though they themselves may be safe. If you use, quotes, the actual product, they can be altered with some of these more toxic agents.
So let me just add to what Dr. Chapman and Dr. Lawson just said. When folks tell me, when one of my patients says, well, I know where I'm getting my drugs from. I'm not buying them on the street. I'm getting them from this person or that person. I would say, well, where are they getting it from? Unless you are manufacturing something yourself, you don't know exactly what's in it. So it all leads back to Dr. Chapman's comment that there's really nothing safe. And so to Dr. Neighbor Stevens' question about what do you tell your kids and grandkids, unless they're actually making whatever it is they're taking themselves, they don't know what's in it. Most of the drugs you buy on the street, they're not being made by the person who's telling you, oh, I know what's in it. No, they really don't. And people are dying every day because they don't know. So the real only answer is just don't take anything. And to Dr. Lawson's point, we have to respect depression and anxiety and all the other challenges and treat them as such and get away from this, whatever's going on. We've got a pill for you. We've got a chemical for you to take to make you feel better, and really get behind the science of how we support people during difficult times.
Well, thank you. This has been an interesting discussion. I want to continue a discussion that we've had in the past, and there are other people who may want to chime in. Early on, when we first heard about this ACE2 receptor, we had a lot of questions. Were those of us who are taking high blood pressure medicines, specifically ACE inhibitors or angiotensin II blocking agents, which are medicines to control high blood pressure? And early on, it wasn't known whether this would upregulate those receptor sites and make us more vulnerable, or lower it and make it less vulnerable.
Excuse me, Dr. Maxey, for those of us who are psychiatrists, what are the names of those fancy medicines you're talking about?
Well,
can you give us a couple of examples?
Yeah, the ones that are ACE inhibitors generally end in the words PRIL, lisinopril, for example, and the ones that are angiotensin receptor blocking agents end in sartan, SARTAN, just as an example. The reason I'm bringing this up is that we know pretty definitively that if you're on high blood pressure medicine, you want to continue it. That it's been rather solidly shown that if you're on ACE inhibitors or something like losartan, an angiotensin receptor blocking agent, that you should continue that medicine. And it in fact can help save your cardiovascular system, your heart and your kidneys, if you do get COVID, which does attack the heart, does attack the kidneys and other organs that have endothelium. So I wanted to make sure that we know that. There was another recent article in the same realm that said we should start our program saying that you need to eat right nutritionally and you need to get exercise. Well, definitive studies have shown that exercise alone does not significantly prolong your life in the effect of COVID. But if you exercise and eat properly and lose weight if you're obese and control your high blood pressure, it makes you less vulnerable to the exigencies of COVID-19. So we know that this disease does have an effect on your cardiovascular system. And we also know that these ACE drugs and also the angiotensin receptor blocking agents, the ones that end in sortin, can have an effect on your blood clotting mechanisms, which is also a feature of the COVID-19. So I invite one or two of our other internists, including Dr. Chapman, if they want to comment on that, because this is what we do every day. And these drugs are legitimate. They come from pharmaceutical firms, even though some of us have issues with that. But I want to add to what we say, common sense. Not only do you need to eat right, be healthy, exercise, but continue to take your medicine and control your blood pressure and obtain a normal, healthy weight. That will help you in this COVID. Any comments from any of our consultants or in the chat room? Anything in the chat?
Dr. Maxey, that is one of the goals of emphasizing the integration of treatment of mental health and substance abuse. One of the things we're very proud of with my patients is the fact that we've been able to find patients who were hypertensive, put them on medication, and control their blood pressures. So if you look over the past 16 years at the cumulative average blood pressures of our patient population, it's astounding in terms of the improvements. We actually are now using home blood pressure monitoring on patients. I have one patient in particular who I have not been able to get him to completely stop using opiates. So he comes in every week, but he had a blood pressure of 180/110, and we put a monitor on him. And for the first several months at home, we were able to detect the fact that his blood pressure was still high. So we came back to the office and we finally got him to admit that he was not taking his medication. Now, over the past 6 weeks, his blood pressure has been perfectly normal. I didn't show that slide, but we actually have a linear graph of this patient's blood pressure. And we can tell whether he takes his blood pressure at home or not, as long as he reports several times a week the way he's supposed to. But when he comes to the office, we now know that he is taking his blood pressure. So that's how you keep patients out of the emergency room and the hospital, because they have all the diseases that everybody else has. They have diabetes, they have cholesterol problems, etc. So we want to treat the whole patient. And that's the idea of the integrated treatment model. And we need the help of primary care, psychiatry, social workers. We need all of this really in a team approach to care.
Well, thank you. Are there any questions in the chat?
There are a few. This is from PhD Kennedy. Are there or could there be networking interactions between policymakers, especially for the insurance companies, to share some of the Black population experiences based on research and ongoing responses to treatment methods? I assume this is for Dr. Chapman.
Absolutely. I actually sent Dr. Maxey an article showing that a commonly used algorithm by the insurance companies actually underestimates the cost of treatment of our patient population. Well, this is something we knew all along. You know, for years, we were getting 20 cents on the dollar for treating a Medicaid patient, when we knew that these were the sickest patients in the community. And if you want to adjust the payment based on how sick the patients are, we probably should have been getting 200% of whatever the other general insurance companies were providing, because these patients need more care. And by giving them more care, you actually save money. I actually did a talk 3 days ago to the National Association of Insurance Commissioners to that very point. The fact that our patients are sicker, providing and paying for those services up front actually saves money. It does exactly what Dr. Maxey was talking about. It reduces heart attacks, strokes, kidney failure, and all of these tertiary things that we seem to love to pay for on the back end.
Thank you,
Any other
Dr.
questions
Chapman.
in the chat?
Just one other for now, I believe. Is there a monitor that can be used all day for blood pressure?
Yes, there is. And I don't know the name of the company, but I can get that to you. We're actually using that and with these coordinators that can actually send the electronic signal of the blood pressure. And Dr. Maxey probably knows about these and can give you the details. But yes, we can monitor patients' blood pressures from home.
In fact, on one of our subsequent programs, we'll probably talk about visual plasmography, which can do exactly that right from your cell phone. I read an interesting article yesterday about the National Football League with all of these players who are out because of concussions and the brain syndrome that goes with that there is a racial adjustment in how they pay the players. And it looks like every place we take care of our patients, we get screwed by some type of red line, racial adjustment or whatnot. If you got a concussion, I didn't know it was different in a white player than a black player, but apparently the black players get paid less. And that's because the NFL agreed to it, the law firms agreed to it. Of course, the players didn't. So we got a lot of work to do. Because we're just getting, I hate to use the word, but it's true. We're getting screwed every place, politically, financially, with this disease, with the treatment, with the masks, with the vaccines. I don't know any place where we come out with a positive answer. And again, I'm not claiming that there's racism involved, but something's going on.
So Dr. Maxey, let me just say that one of the things that Dr. Chapman mentioned is the organization Leadership Council for Healthy Communities. We've also had Dr. Pointer, Reverend Dr. Pointer, talk to us about the work that he's done up in Buffalo area, up in northern New York State. And I think that they are examples of folks who are working with the elected officials, working with the clergy, working with the healthcare community to address these issues. So yes, the problem is huge. And at the same time, we have folks like Dr. Chapman, Dr. Lawson, Reverend Pointer, and others who are out there. And the reason I say that is just to encourage all of us to look for folks in all of our communities around the country who are doing something, who are making those connections and support those efforts. A lot of these, like obviously Reverend Pointer's church, the Leadership Council that Dr. Chapman talked about, are not-for-profit organizations. So you can, in fact, support those organizations. There's another one, it's called the Black Health Trust, which is a not-for-profit organization that's trying to do things in our community that can also be supported easily because it's a not-for-profit organization. So I know Dr. Maxey, we get very much upset about all the things that are going wrong. I just want to point out some of the things that are going right so that we can encourage those things.
Thank you so much, my doctor. We're getting close to the top of the hour. I think we've had a good discussion by our consultants, Dr. Chapman and Miss Victoria Burrell. I hope I pronounced that right. With the input of Dr. Lawson and others. We've got a couple of minutes. Michelle, can you see if anybody wants to make a quick comment?
Does anyone want to make a quick comment?
I see Cheryl
today?
Holder has a hand up.
That the famous Cheryl Holder from Florida?
Okay, great. I'll ask to unmute. There we go. You're live, Cheryl.
Hi, good afternoon, everyone. Great talk as always. I just wanted to bring up with children that we're seeing with COVID, because our numbers are skyrocketing in Florida. And one thing that's consistent is BMI. So when you made the comments about diet and exercise, it's also for children. The ones who are being hospitalized and not doing well have much higher BMIs. So if the families are out there, and we know childhood obesity is a huge problem in the Black community, once the vaccine 12 and over, anyone with children who are obese definitely should push them to get vaccinated because they're not doing as well. Everybody should be vaccinated, but especially the BMIs, those are the ones that are being hospitalized and not doing well.
Dr. Holder, we know you, but can you introduce yourself for just a moment? I'm so happy that you joined us.
Hi, Cheryl Holder. I'm in Florida at the Herbert Wertheim College of Medicine, doing a lot of community outreach. I work with a group that the Black doctors created and we got funded called Keeping the Faith to Fight COVID-19 in our community. And so we're out every day doing Zoom talks and working with a lot of the young people. And this is what we're seeing. They're just not getting vaccinated, especially the children, and the hospitalizations are skyrocketing for our children. And it's definitely Black and brown kids that are not doing well. So we have to sound the alarm on the obesity and the impact on children.
Thank you so much.
Thank you.
Dr. Walsh, you see anybody else?
I do not at the moment, Dr. Maxey.
Okay, we're close to the top of the hour. Dr. Neighbor-Stevens and Dr. Walsh, let's have last words and go to Ms. Ager and Pastor Pointer.
Well, I'm not going to go through all of the statistics, but I did want to just reiterate that if you look at the statistics of all of the demographic and ethnic groups, Black non-Hispanic is still at the bottom of the heap in terms of receiving vaccinations. And we're not making much progress in terms of availing ourselves of the vaccine. So again, I just want to really urge you to think seriously about protecting yourself and your family. If you have any questions, please reach out to your physician or healthcare provider to get your questions answered. If we haven't answered them here at BHT, and we've been trying, but if we didn't get your questions answered, please go to your trusted messenger and seriously consider taking the vaccine. We feel that that is a good thing for you to do. You need to think about it.
Dr. Walsh?
Thank you, Dr. Maxey. There was a comment about whether CBD is legal or illegal, so people aren't buying it from their dealers on the streets. Okay. Alcohol is not illegal. You don't have to buy it from a dealer on the corner. There are a lot of things that are not illegal that we think need to be either not done or done in moderation. So I just want to make the point that as to go back to Dr. Neighbor-Stevens' question several minutes ago about what parents tell their kids, I think making sure that we have communication open around the area of substance abuse or eating in ways that aren't healthy, eating things that aren't healthy. It doesn't have to be illegal to kill you or hurt you or make you more sick. The comments from Dr. Holder about body mass index, BMI. I think there's a lot of opportunity for us to open up those conversations and take some of the things that Dr. Chapman and Dr. Lawson talked to us about today, and Dr. Maxey talked to us about today, so that good health, whatever's coming to get me, I want it to have to fight through a healthy body. Whatever's coming to get me, because there's stuff coming to get me. I'm not paranoid, it's coming to get me. And I want it to have to fight through healthy lungs, good blood pressure, a fit person. And I just want us to encourage ourselves to do that.
Well, thank you so much. And as my final word, I want to encourage common sense,
Amen.
self-protection, continue to distance yourself from people. If you're inside and you're not vaccinated, you don't know whether they're vaccinated, I urge you to continue to wear masks, gloves when appropriate, and please be vaccinated. The numbers absolutely show that the people at most risk are those who are unvaccinated. And those who are obese, those who have diabetes, is not well controlled, those who have high blood pressure and it's not well controlled. Please use common sense. And if anybody wants me to join them on a lawsuit to the governor of Texas and Florida, I'm down with that. Ms. Brenda Lee Ager and Pastor Pointer. Ms. Ager?
Well, good morning, everyone. I was inspired so much by today's session. So I wrote this little song about 20 minutes ago. Hope you like it. We are the answer we seek. As we learn, we listen, we teach. We say what our future will be. Living for, bringing for the world of healing and love and peace. That's it.
Can that be the Black Health Trust theme song?
I was thinking the same thing.
Let me do it again. Let me do it really good this time.
Go ahead.
We are the answer we seek. As we learn, we listen, we teach. We say what our future will be and bring forth the world of healing and love and peace. Let's all say the last line. And bring forth the world of healing and love and peace.
Amen.
Yeah, I'll be humming that the rest of the night. Praise God. Let's give thanks. Let us pray. Oh Lord our God, we give you thanks for Ms. Victoria Bure and Dr. Edwin C. Chapman. Master of existence and Lord of lords, we do not rely on our own good deeds, but on your great mercy as we lay our needs before you. Lord, hear. Lord, pardon. Lord, listen and act. What are we? What is our life? What is our love? What is our justice? What is our success? What is our endurance? What is our power? Lord, our God and God of our fathers, what can we say before you? For in your presence are not the powerful as nothing, the famous as if they had never existed, the learned as if without knowledge, and the intelligent as without insight. To you, most of our actions are pointless, and our daily life is shallow. Even the superiority of man over the beast is nothing, for everything is trivial except the pure soul, which must one day give its account and reckoning before the judgment seat of your glory. So with all these things, O God, we ask simply for your continued mercy and your guidance. Give our hands good work to do, and let what we do and say be to the glory of your great name. And we will carefully praise you forever. In Jesus' name, amen.
Amen.
Family, another outstanding Sunday.
Thank you so much, Mr. Simon Cooper, Mr. Keeney Stevens, and Ms. Michelle Simmons. The wonderful guests, Dr. Chapman, Ms. Burrell, and my two wonderful co-moderators, Dr. Barbara Neighbors Stevens and Dr. Ivan Walks. Thank you so much. Have a good night, everybody.
Thank you,